The Health Finance and Governance Project is a USAID initiative working in about 45 countries. We work on improving access to priority health services through improved financing, governance, management, and operations. We're very interested in the quality of care. In particular, we've been doing some work on the governance arrangements and institutional arrangements in countries around the world for improving quality of services, which is why we're so delighted to have this session here today. We will, as you'll see from the agenda, we'll be talking about, we're going to have a little polling exercise in a moment for all participants to participate in. Then we'll talk about the Ideal Clinic program in South Africa, about some of the latest thinking and science around quality of care from IHI. And then we'll be returning to a discussion about some implications for South Africa and indeed the rest of the world. So our objective today is to share some of the lessons from South Africa on setting up and expanding quality primary health care services through their Ideal Clinic program. We are then going to review the latest international evidence on what works for sustained improvements in quality primary health care in resource-constrained environments. And then we're going to discuss some of the future challenges and approaches to expanding and sustaining quality primary health care in low and middle-income countries across Africa, but also perhaps in other parts of the world. I'd like to start with a very short poll just to get some sense of who's online. So as hopefully you'll see on your computer, if you're assuming you're using your computer, there's a little polling feature, and we'd like you to put some questions into the right-hand side of the screen. There's 3 questions. What type of organization do you work in? Secondly, are you actively involved in improving the quality of facility-based care? And thirdly, did you attend the recent Africa Forum on Quality and Safety in Healthcare? If you could click on some responses, and then we'll hopefully get a sense of who's online. I'll just wait a few seconds. Okay, so just waiting for the... So this will give some sense of who's participating in this, and we will be hearing a little bit more about the Africa Forum a bit later for those that haven't been involved in that. So some initial results coming up showing that we have quite a lot of people working in non-government organizations, a smaller group working in government, and a middle-level group working in the private sector. Majority of our people on the line do seem to be actively involved in improving quality of care, and it seems that most people online did not attend the forum in Durban, so I'm looking forward to, we'll hear more about that from IHI shortly. So I'd like to move on now and just introduce the speakers on the webinar today. We have Jeanette Hunter, who's the Deputy Director General of Primary Health Care at the National Department of Health in South Africa, where she leads the Ideal Clinic program. With her, we have Dr. Shaida Asmal, who's a Senior Technical Advisor at the South African National Department of Health, where she supports the primary health care branch and the development of scaling up the integrated clinical services management model, which is featured as part of the Ideal Clinic program. And then we have 2 colleagues from IHI. We have Dr. Pierre Barker, who is the Chief for Global Partnerships and Programs Officer for the Institute for Healthcare Improvement, where he's responsible for strategic partnerships around the globe, and IHI's programming of work outside of North America. He's joined by Dr. Soji Teti, who's the Executive Director of the Africa region at the Institute for Healthcare Improvement, where he provides strategic and technical relationship guidance for IHI's work in Africa, whilst also securing new opportunities across the region. So that's a brief introduction to our speakers today. We're going to start with talking about the Ideal Clinic in South Africa, and I'd like to hand over to Jeanette in Pretoria. Jeanette, over to you.
Thank you, Bob. Good morning, good afternoon, good evening, everybody. It's my pleasure today to talk with you about our Ideal Clinic Realization and Maintenance Program. So this very busy slide, I think very aptly busy because it's a real reflection of the dynamics and complexity in the health system. So with this busy slide, I aim to explain to you where we locate our clinics in South Africa. So the dark blue ellipse labeled primary health care facilities, quality, comprehensive, person-centered care. That's what we want our facilities to deliver. And we call it primary health care facilities because we have both clinics and community health centers. And of course, the difference between clinics and community health centers is that clinics are open 5 days a week. Community health centers are open 7 days a week, 24 hours. So surrounding the ellipse, you'll see the different services that support services within the clinics like school health services, ward-based primary health care, outreach teams. We work with NGO services. From the clinics, together with all the partners, we run health campaigns. We also work with private providers who we contract to assist with services in the clinics. And then, of course, you need to have access to social and psychological services for your community. The block on the outside shows the secondary and tertiary level of services where you would refer your patients to from the primary health care setting. And so it would include diagnostic services as well as treatment services. So moving on, this slide aims to explain to you what the Ideal Clinic framework comprises of. So you see there that we have 10 components, starting with administrative processes, going on to what we require for integrated clinical services management. And then you have the component for medicine supplies and laboratory services. The next one is all about human resources for health. Then your support services component, your infrastructure component, and for us, infrastructure is about brick and mortar, about your information and communication technology, as well as your essential equipment in your health facilities. You have a component for health information management, for communication, for the kind of support that our clinics need from the district health system. And then, of course, the support that you have from your implementing partners and stakeholders, and those are typically NGOs and academic institutions. We have three categories of ideal clinics. So if your clinic achieves between 70 and 79% in terms of the functional elements, you will have a silver status. 80 to 89, you'll have gold status, and 90 to 100, you'll have platinum status. So the previous slide shared with you that we have 10 components, 32 subcomponents, and more than 200 elements. And so these elements are weighted because not every element is as important. Not all elements are equally important. So you would have vital elements, essential elements, and important elements. So why the Ideal Clinic Realization and Maintenance Program in South Africa? And it's got this name, Ideal Clinic Realization and Maintenance, because when you look at the 10 components, the 32 subcomponents, and the more than 200 elements, you'll see that nothing is new. There is nothing that a clinic should not have had since centuries past to be able to function optimally. And that's why we're not calling it an implementation program, because I think you implement something that's new, but it's to bring what should be into reality through this program. So why? In South Africa, we've got a standards authority called the Office of Health Standards and Compliance. So they did a baseline assessment of all facilities, clinics and hospitals in 2010-11, and they released that report in 2012. So when you look at these three graphs on the screen, you'll see the one on your left is for clinics, the one on the top right is for district hospitals, and the one on the bottom right is for all other higher levels of hospitals. And so you could see this, the score grading there, that the brown bar depicts all those facilities that scored under 40%. And you move right along up to the dark green bar that depicts facilities that scored up to 80% against the standards of the Office of Health Standards Compliance. And you will notice that between these three categories of health facilities, the clinics did particularly badly. So most of the clinics scored less than 40% if you look at that graph. And we realized then as the National Department of Health, especially move along a couple of years from 2010-11 to 2013, we found that there was no change. Even though when the office did the baseline, they shared results with clinic managers, with district managers, with provincial managers, we found that 3 years later, there'd been no positive improvement in the case of the clinics. We then realized that we needed to do something proactively from inside the department to strengthen the ability of managers on the ground to make improvement interventions themselves in order for the office to find them compliant when they do their inspection. I just have this slide here to remember to tell you that we immediately set up a monitoring and evaluation system for this continuous quality improvement program called the Ideal Clinic Program. And so we set up a web-based monitoring and evaluation tool, but for those facilities that do not have access to the internet, we also use an offline module for them. This slide also just to be able to show you the different kinds of reports that the system can yield, and I'm not going to go through it. You could rather ask questions later about it if you are interested. So how do we go about doing this? I said what we're trying to do is to empower the frontline workers and sub-district and district managers to be able to identify the weaknesses in their facilities and to correct those weaknesses. And so how do we do it? We model our work on the Plan, Do, Study, Act cycle of implementation research. So we drafted a plan for the country with a collaboration of different stakeholders across the country, from public service, from public sector, from private sector as well, from the academia and the NGO sector. We drafted an implementation plan that was in 2014. And so in terms of the do, from April to June every year, our financial year starts on the 1st of April in South Africa, the government financial year. The facilities themselves do their status determination. They then work on correcting the weaknesses. For example, if the medicine room doesn't have a thermometer, they get a working thermometer so that they can measure the temperature in the medicine room. And then we have peer reviews in November of every year. And there's further corrections in terms of weaknesses that the peer reviewers find. And then we report at the end of the year, at the end of March of every year, we then report our progress in terms of ideal clinics in the country. This is just a graph telling you the story of one particular clinic called Katie Motibatsi Clinic in Gauteng in South Africa, showing that in July 2013, they only had 41% of their elements functional. And through going through this process, they ended up with 82% in February 2014. This is our progress to date. It shows the 9 provinces of South Africa. It shows you the total number of facilities when we start on the left, moving to the right. The second column is the total number of facilities in the country. It then shows achievement for the various years that we've been implementing this program. So 15-16, we moved from almost 0 clinics to 322 ideal clinics. Unfortunately, when you look at the next column that shows those that maintain their status, you'll see that not all maintained ideal clinic status, that there were slippages. And so as we move to where we are today, where we have 1,377 facilities, you'll see that every year we make gains, but we also lose some clinics. So sustainability is definitely still a problem. The lessons that we've learned so far is that the main bottlenecks relate to infrastructure, staffing, and supply chain management issues. We've also learned that there's a direct yet inverse correlation between whether facilities have a dedicated facility manager and whether they can work to ideal clinic status. And then, of course, what we've learned is that the peer reviews serve as additional training for district scale-up teams. Teams learn a lot, both from visiting well-performing facilities as well as poorly performing facilities. They always find lessons in the district that they are peer reviewing to take back to go and improve things in their own districts. So our corrective interventions, of course, is to address the 3 main challenges, and I don't have the time this afternoon to go into that, but if there's questions on that, we could respond to those questions. And that's the end of my presentation. Thank you, Bob.
Jeanette, thank you very much indeed. That was very clear, very helpful indeed. You're a little bit ahead of time, so we can spend a bit of time asking some questions and getting a little bit more detail about certain aspects. I'd like to ask all those listening in, if you could use your chat feature now to send in questions, and if you could ask for those questions, when you click on chat, can you choose all panelists, so all the panelists will see your questions. So please could you send in your questions. And whilst we're waiting for those questions to appear, I'd like to kick off, Jeanette, with a couple of questions. But I'll start with a question around the continuous quality improvement. You said this whole program is around continuous quality improvement. Many of us have seen this, been involved in quality improvement in other settings, and we often refer to this when we're talking about clinical care or public health programs. And could you just give us a little bit more detail about how you undergo continuous quality improvement around clinical care in particular and public health programs, and give a little bit more detail on that? Thank you. Over to you.
Thanks, Bob. So to use one of the key barriers, supply chain management, for example. So when the facilities do a status determination, and we choose our terminology very consciously, so it's not an audit or an inspection, but it's simply determining the status of the facility, because this is not a punitive intervention. And you find that the clinic, for example, doesn't have the required surgical sundries, for syringes, needles, etc. So you would then go down, if it's a bunch of clinics in the same district, you would go down to that level and have a conversation, find the root causes of those weaknesses observed. And the example of supply chain, to our shock, we found that some of the poorly performing districts didn't have a structure for supply chain at all. So I don't know how we thought we would get surgical sundries, for example, into the facilities when there's no dedicated staff for running a supply chain management for some of the districts. And so then we work together with the districts and the provinces to create posts, to appoint people to posts, to make sure that they either have the correct skills, or then you do training if you can't find the skills. Because remember, we're talking about the whole of South Africa, And some of our areas are very rural. Young people leave as matriculants, don't study in the cities, and then they choose to stay in the cities. So a lot of times we have to find people and then find training programs to skill them up to be able to do their work. I don't know if, I think Shaida could add to that as well, Bob.
Thank you very much, Jeanette. So coming in is that in terms of the quality of clinical care, component 2 of the ideal clinic is very specifically around looking at integrated clinical services management. And this is about delivering quality health care to improve health outcomes that address the burden of disease in South Africa very specifically, but looking at it in a very patient-focused manner and moving away from a historical hospice-centric approach that we had. And that it, you know, I would really like the participants to understand that the ideal clinic is about fixing the health system challenges, but the focus not being lost, that it is around us being able to deliver quality care to the patient. And in doing that, we've also introduced as part of the ideal clinic process and as one of the elements that we have clinic committees that provide governance, local governance, and ensures that local communities are involved in ensuring the health of that local population. So these are some of the efforts in terms of ensuring that we deliver cost-effective and efficient services.
Okay, thank you very much for that. We have a few questions coming in, so I'm going to read them out and then hand back over to you. I'll read out maybe 2 at a time. So, and not everyone's given their name, but from Indira Narayanan, we have a question about, could you give us some more details about how individual centres are they assessed? And do you have trends in the score for centres over a period? And the second question is, do you include private sector facilities? Over to you.
Thank you. So how are individual facilities assessed? So we have this online monitoring and evaluation system that speaks to the 206, I think at the moment, elements. So if you have an element, for example, that speaks to access to the essential medicines at primary healthcare level, when you go onto the software to that element and click onto it, you'll also find a checklist that then displays exactly what you mean when you talk about the essential medicines at the primary healthcare level. So as I said, in terms of our plan, do, study, act cycle, between April and June, the facility managers do their own status determination, and then they do their fixes, whatever or identify the shortcomings are corrected, and they also call in the help of the district management, provincial management, and even us as the national office to assist with some of these elements. And then the fixes then take place from July to October, and all this timing is a bit artificial because there will be a lot of overlap in the different facilities in terms of where they are at in terms of the cycle. But in November, like clockwork, we do our peer reviews. We have 9 provinces in South Africa. The 9 provinces are further subdivided into 52 districts. So we would take one team from a district to go and peer review primary healthcare facilities in another district, and then so District A will peer review District B will peer review District C, and so on. And then we come out with a final result. Yes, we do have trend scores. As I've displayed on one of those slides, you can see how the facilities move from having very few functional elements to becoming ideal. And then, of course, we also observe that some do slip. So a facility would slip from having scored 82%, maybe down to a 70, but worst of all, if they slip from being ideal to no longer being ideal. So we do have strength scores per facility, per element. We, of course, can aggregate these scores into district scores, provincial scores, and then you have a national score as well. Bob, what was the last question?
Do you cover private sector facilities?
Oh, okay, no. Not at the moment. We do not have private sector facilities. A private sector facility would typically be a general practice, but the general practitioners in South Africa provide very limited primary healthcare services. They don't provide the full package of primary healthcare services that we offer our client communities in South Africa. And because we have a grave problem in our public sector facilities, as you would have seen from that graph of the Office of Health Standards and Compliance, we do need to focus on fixing the public sector facilities first.
Thank you very much. Right, a couple more questions. We have two related questions, really. First of all, have you noted any difference in responses between facility types, so by the size of facilities or their staffing levels or their designation? Are there any trends that you've noticed? And related to that, can you say a little bit more about the dynamic of improvement? What clinics have been able to improve faster and which clinics struggle more? And what makes those differences? Is it related to resources or to coaching?
Okay. So difference in responses, yes, we have, size-wise, we have a wide range of health facilities. So you would find a tiny community in a rural setting where you almost have like a one-person facility, because they could see a maximum of 20 patients per day. And then you can move to very large facilities where they see something like 1,200 patients per day. And what makes a difference are those three things. Number one, infrastructure, space requirements. So we have specifications for the space that you need in terms of the size of the population that you serve. And so we have specifications for your consulting room, we have specifications for your delivery room, you have specifications for where you treat emergencies, and so on. So number one, you do need a facility that has the space to accommodate the kinds of services that you are mandated to deliver to the size of the population that you serve. So if you don't have the space, you are lost. You will not be able to progress to ideal. Number two, you could have the space, but if you don't have adequate staff, you won't progress either. And then, of course, if you don't have a functional supply chain system to bring in the supplies, you won't progress either. But I must say, you could have a facility with adequate space, with adequate staff, and not necessarily any key problems with the supply chain. But if the staff haven't bought into the system, you will not get the kind of results that you desire, whereas you could find a facility that infrastructurally is perhaps struggling and they do not have the right number of people servicing the size of the community, but where there's buy-in and commitment and they see the rationale for the program, you would be surprised to see a facility that's struggling with infrastructure actually getting things right and moving towards being ideal. And so for me, those are the dynamics of improvement. I must say what helped us in this country is that this program was adopted by the presidency, so it was driven out, it is still driven out of the presidency. And in the beginning when we started, people were feeling, that this is just bringing an additional burden on the many tasks that they already have, and I think they were wishing that we would just disappear with this program. But once the message got through that the program is here to stay and that these are things that you have to do in any case, you do have to see that you have functional oxygen cylinders. You do have to have your medicine stores filled with the required medicine. You do have to see that you have backup water. You do have to be able to file patient files neatly for quick retrieval. People started buying in more and more, and yeah, the program is really alive in South Africa.
Thank you for that. We have a few questions now about the financing of the program, so maybe I'll just read those out. Can you say, is there any connection between the ratings you've achieved and the level of financing to those facilities? Is there any link to insurance reimbursements or other forms of payment to the facility? Secondly, from Diana Silimperi, do you have data on the returns of your investment? Any cost per clinic, around score improvements and changes in clinical outcomes linked to the how much it costs to make those improvements? And lastly, could you say about, you talked about the peer review process, could you say a little bit, this from Richard Killian, how that peer review process is financed?
Okay. People won't like me saying this. I have to say we look out for wastage. So let me give you an example. When we started the program, still planning the program, we had envisaged that we would need scale-up teams in every district, in each of the 52 districts. And everybody was asking, where are you going to get the people from in economically constrained environments such as what South Africa is going through at the moment. And 5 years ago, in 2013, it was no different. But I had observed before we even implemented the program, whenever I visited facilities in districts, I was met by a myriad of people. There's a district manager, there's a deputy district manager, there's a sub-district manager, there's a clinic supervisor, there's a PHC manager. So I knew those people were there. They may not have seen their roles at that time as becoming a team, focusing on improving the quality of the environment and thus the quality of services within clinics. But we then gelled them into a team, oriented them, trained them in terms of the program and got them to do this. So what I want to say is often when you look around, there's already resources that could be applied differently towards continuous quality improvement. But you will not get to the desired level of quality if you do not have a budget for infrastructure improvement, if you do not have a budget for your medicines and your supplies, if you can't pay staff. So, of course, the improvements are linked to having budget for this. So, Shaida had spoken, when she spoke earlier, she mentioned that we want to move from a hospice-centric system to a more primary healthcare-oriented system. So what we do at the national, I sit with the National Treasury and the 9 provincial treasuries, and ever since 2013 to now, we have effected through debate, dialogue, and motivation a 10% shift away from hospitals to primary healthcare services to make these kinds of improvements, because we believe in health promotion, keeping people healthy. So primary prevention of disease as well as secondary prevention of disease, that we've got to invest there instead of overly investing in hospital services. So we had an external patient satisfaction survey that also shows the strong correlation between ideal clinics and patient satisfaction. we have two parties in South Africa working with PEPFAR funding. So we have CDC and we have USAID, and the CDC group also did some data analysis, Bob. I don't know if I've even told you about this, but they've also found correlation between better status of 90/90 targets and ideal clinics. And the peer reviews are funded by a national fund. So we have, I think, 92, Shaida could correct me, 92 teams of 2 people, so about 180 teams. And so we do have the expenses of hiring cars for them to go around, because they have to travel out of their own district to the district that they are reviewing. So we do hire cars. You need the money for accommodation. You need a per diem for them to have sustenance for the day. And so that money we keep centrally at national for the peer reviews. And let me stop there.
And could you respond to the second question about whether you've been able to do any analysis about return on investment? I mean, how much you've had to this investment into making sure that there's budget and things, and actually the improvements. Have you been able to make that case? I imagine people in other countries might be interested in making this case to their own ministries of finance and departments of health, and may need that return of investment analysis.
We haven't done it, but the Priceless group at this university is just about starting a study on that return on investment for ideal clinics. But the 52 districts have a budget for health service delivery. And so all we're getting them to do is to be able to spend their budget in a way that provides a comfortable service for the patients when they come to the clinic, and then in that way act positively on people's clinical conditions. So let me say, for example, when you have the infrastructure, you have enough consulting rooms, you have a passage, you have 2 doctors, they each in their own consulting room, you have 2 nurses, they each in their own consulting room. And we've had clinics like this. But there's only one sphygmomanometer and 1 stethoscope. And they have to wait in line to use a stethoscope. So I don't think, and this is why this found traction with our president, with our minister, with our DG at national, and the support of the treasuries to implement as well. Because it's just common sense. How do you have 4 people who could attend to patients, but you have 1 set of tools? So it's about getting the tools to everybody to be able to assist the client communities when they come to our health facilities. But yes, I'm quite excited that Priceless is embarking on this study, and we'll see what they come up with. It seems like when the clinic's roof leaks, do you really have to do a cost-benefit analysis, or do you just fix a leaking roof? When people don't have chairs to sit on, do you have to do a cost-benefit analysis, or do you get them chairs to sit on so that they can wait in comfort while they are waiting for services? Shaida, have you got anything to add there?
So just to expand on what she was saying, really this process has allowed district managers, sub-district managers to start prioritizing facilities where they need to engage more and where they need to put their resources. It's allowed people to actually have more sight of where they're putting their resources, rather than sometimes it felt like it was a dart game and wherever the dart fell. Whereas this is it's more structured, that people can see that, look, this is a particular facility. If we just go in and improve their equipment status, we should have them functioning in a much better way. And that's what this has allowed us to do. So looking at, one of the questions I think that somebody's posed, this is allowing us to influence how budgets are being used per unit facility. Yeah.
Thank you for that. We'll have one last couple of questions from Catherine Connor. Related to that last point, have there been any changes in responsibilities across the levels of the system as a result of the Ideal Clinic program? Have managers been more empowered or given more delegations, etc.? And secondly, you mentioned about these silver, gold, and platinum scores. Is that scoring made public?
Okay. There's been no changes in delegations. We have in South Africa the Department for Public Service and Administration that in their regulations define the levels of responsibility and the delegations that goes with that. So we're still operating in terms of those delegations. But in short, the delegations people have currently at primary healthcare level, I think it's sufficient for them to organize their work. There's a big debate about delegations in large hospitals, but that's a completely different story. The achievement of the facilities, a couple of MECs, I know, for example, the political principle, let me use this language so everyone understands. The political head in the provinces have awards at the end of the year where they then celebrate the Ideal Clinic achievements of the clinics, but it's very much an internal process. But then, of course, every facility is supposed to have a clinic committee, and I use the word supposed to have because not all have. I think we've got about a 60% achievement in that area. So through the clinic committees, the communities then become aware of where their facilities at in terms of Ideal Clinic achievement. I just want to, since this is a last round of questions, Bob, I also want to add that even before we started the Ideal Clinic process, the Minister directed that we appoint at each district a group of clinical specialists to attend to our high level of maternal mortality. And so we had a group of 7 where you would have an anesthetist, an obstetrician, advanced midwife, primary health care, a family physician, primary health care specialist nurse, pediatrician, and a pediatric nurse. And they have immediately adopted the Ideal Clinic framework. I didn't even look at them as becoming part of the district scale-up teams. But when they looked at the framework, they said, but this is what we need. If we are expected to improve clinical outcomes within a district, we need to support this framework because this framework empowers the facility. It provides the facility with the supplies and equipment that's needed to be able to provide the kinds of services that will bring better clinical outcomes.
Jeanette Scheider, thank you very much for that. We're now going to move on to our second session, and I'd like to hand over, which is focusing on the quality of care and some of the science, and also about some news from the recent Africa Forum in Durban. And I'm going to hand over to Pierre and Soji. Pierre, over to you.
Thanks very much, Bob, and hello, everybody. This is Pierre. I'm really delighted to have this opportunity to join this really interesting seminar. Before I sort of launch into a sort of a description of the way in which we look at quality in many of its aspects, I wanted to just make a couple of commentaries and certainly congratulate Jeanette and Dr. Scheider for an extraordinary achievement, I think, in South Africa in terms of where they have brought the clinics. And I think, excuse me, what this shows is really how it's possible with a systematic effort to ensure that the essential elements are in place, and the dedication of the teams that go around once a year, and also the use of some really interesting and important aspects like the peer participation and community participation, which I think has probably led to in some measure, to the success that they've seen in bringing on so many of these clinics and into the ideal category. I think what I'll be talking about a little bit is how you really need these different aspects of quality to get real performance across the system. The part of the system that of quality improvement that was focusing on really is essential. You cannot undertake quality unless you have the basic pieces in place. And I think, you know, what Jeanette identified was, you know, the core elements of personnel resources and infrastructure and health information. And I think she noted, you know, that if you don't have the space and the staff and the supply chain all working, and I think probably the managers, the engaged managers, you're not going to have a functional clinic or certainly achieve that ideal status. But I think what Jeanette was also talking about was the buy-in and commitment, and I think it seems to me that the staff really appreciated the fact that that they were being supported by their peers, and that there was a lot of learning that was coming, and that they were able to see from peers from maybe across the valley or in a different town that this was possible, and learn from those ideas. So I wanted to just state right at the outset that this is really a significant achievement, and certainly by the data that Jeanette showed us, a very significant improvement in the classification of clinics that conform to that ideal status. I think where we want to go with the conversation now is, so if you have all of that in place, what do you do with it? And I think Jeanette alluded to the fact that there may now be some emerging evidence that if you do have all the pieces in place, certainly in terms of the HIV chain, for instance, the 19-90-90 targets, that you probably will see improvement in the performance of those, and that makes a lot of sense. If you don't have all of this in place, I cannot imagine how you could deliver an effective HIV service. So if we look at could I have there we go. Okay, perfect. This is the system of integrated quality management that is described by Joseph Joram, who we look to really for helping us to understand how integrated systems work, particularly in this era where we are moving from what has been the dominant way of looking at quality in systems, which is mostly around inputs, to a more balanced view of quality, which includes the Donabedian concept of, if you want to improve your outcomes, you need to take care of both the inputs and the processes. What Joran said is that learning is at the center of improving quality. If you don't have a way of being able to watch what you're doing, learn from what you're doing, and build that knowledge into your planning system, you really are going to be only using a fraction of the information that you have available to you. If you're just relying on your own best ideas for quality planning, you're in trouble. So that was the first thing that Joram said, is absolutely you need policy, the inputs, the structures, and the workforce that we've just been talking about, but you also need adaptive designs that can adapt to what you learn. The second important piece, and this has probably been one of the most controversial pieces, and I hope what you'll take away from what I'm about to tell you is that there is no competition between an intermittent quality review, the district review like we've just been hearing about, which we would call external monitoring, and the internal monitoring system that both Joran and Edward Deming were promoted. There should be no contest. We absolutely need external reviews for verification and support of systems in the way that Jeanette has described. But what I'm hoping to persuade you is that, excuse me, to achieve real rapid improvement in the performance of the processes, once you've got all of those systems in place, you probably need a reliable internal monitoring system as well, and we'll talk a little bit about how that looks. Again, learning essential. You absolutely have to learn from that. From the aspect of the quality improvement, I think that Jeanette spoke about the PDSA cycle, and I'll show you that there are sort of two ways in which you can use a Plan, Do, Study, Act. One is the annual cycle that Jeanette spoke about, where there's a lot of planning, a lot of structural and review changes that happen at the front end, sort of a setting out to do something differently over time, coming back over 9 months to a year to see how things are going, and then making a decision as to whether you need further design in your planning. So that's a long Plan, Do, Study, Act cycle, and we see a lot of this has become quite popular, and many of the countries that we've worked in have quarterly reviews where they review the performance, they feed back that data, they help clinics with the redesign process, and that has become quite a popular way of improving quality. There's another much more rapid Plan, Do, Study, Act cycle that I'll show you, which happens at the front line with information that is generated by the nurses at the front line, and these cycles are 1 week long or maybe 2 or 3 weeks long, but they are constantly reviewed. They're much smaller scale changes, and they are multiple PDSA cycles that are directed mostly at process improvement. So improving a key process. For instance, is a woman given oxytocin right after delivery is a key process which will save lives and prevent hemorrhage, and that process can be improved very rapidly over a matter of weeks by applying different ideas until you get the system right, and then you fix it and you say, this is the way we're going to do things from now on. I'll show you a little bit about that. So I'm at the risk of confusing you. I want to make sure that we understand that there is a very important role for the health system supports in the way that Jeanette has described with these verification processes and support processes, and then there is a handing off of the responsibility, if you like, for rapid cycle improvement within the clinic. So let's talk a little bit about internal and external quality control. So the primary purpose of internal quality control is to maintain control once you've got things worked out. Okay, it's evaluated continuously, meaning excuse me, every week or every month. Most of the continuous quality improvement in South Africa, there's the DHIS that reports every month. Some of the national reviews come out every quarterly, but so clinics and managers would have access to monthly data to be able to track whether things are improving according to goals. And the primary recipient of that information is the frontline managers and staff to be used for improvement. The external quality control, which can work very closely with this, primary purpose is to verify that the control has been maintained. Typically, it's a very intensive process. Jeanette spoke about over 200 elements. This is a big undertaking, and it's not measuring a key process that you might be trying to improve, like oxytocin delivery at the time of birth. And so therefore, typically these external quality control processes happen more infrequently and more intermittently. It's the basis of accreditation, although the process that Jeanette just described actually is a much more modern view of an accreditation process which is now gaining a lot of popularity, and some of you may have heard of SafeCare, which is a system that Kasasa and Farm Access have promoted around Africa, which has the same kind of graded improvement of clinics and hospitals that Jeanette just described. It's used to review and feedback information on standards, particularly input standards. So you'll find that this process is very adept at studying if the pieces are there. Are the essential medicines there? Is the supply chain working? Do you have the right personnel? Do you have the right space? These are the things that are easy to measure using this kind of an approach. And we have, before we developed this more of a crossover, it was the sort of backbone of what we used to call, we still do call, quality assurance. Why I say it's kind of changing is because many of the modern methods of quality improvement are now being incorporated, particularly things like systems thinking and learning and the PDSA cycle. So I hope you're still with me on this. Let me take you through an example, and it's just a made-up example, and we could even assign this example to oxytocin. So you start off with a plan on how you are set up. So you make sure that people are trained, they need to know when they use oxytocin, that they have the infrastructure, they have the drugs, they have them at the right place, you have the right trained people, and you then have a system. You have a system that you then have to go out and measure and see how it's performing. So let's say, for argument's sake, that when we measured the system in the clinic over time, we found that generally oxytocin was being given somewhere between 35 and 45% of the time. So it bounces around, and we would say that system is designed to deliver oxytocin at around 40%. That is the property of the system, is that design, is that outcome. And there are a couple of things that might happen. So what might happen is that you could be watching this over time, and you could find that you're slipping out of this zone of control, and that you're measuring it continuously, and you notice that it's not performing as well as it used to. Now, you know the system can deliver at between 35 and 45%, but now it's performing at 20%, so you have to do something. If it's a simple fix like a supply chain, there's no longer any oxytocin reliable, you can just fix it. You apply standard work. You make sure that the supplies are there. But there may be some knowledge. Somebody may have left the clinic, and the knowledge may have left with that person, and you have to get back and work out what actually happened, and you may have to apply some rapid PDSA cycles. Typically, small slippages like that can be fixed by some simple just-do-it type interventions. However, if you then decide, well, that's not good enough, actually 85% of all women should be given oxytocin. Now, we know that that system is designed only to deliver at 40 to 45%. And what Jeanette said earlier was that just by showing people their results, as happened with the Office of Standards and Compliance, you're not going to really see an improvement. They need something else. They need a method to be able to get you to your new goal. And the method that the IHI uses is the model for improvement, which has as its heart a very rapid PDSA cycle. So we teach the staff how to analyze their own system, come up with some theories about why is it only 40% of the time. And some of this could just be simple input stuff, that you don't have the drug at the right place, you don't have the staff who know what they're doing. But often what we find is if you put the drug there, if you put the staff, if you train the staff, they just won't deliver the drug to the mother at the right time. And that's because there's some local challenge to it. Maybe they're not organized so that they can give mothers the right attention because they're distracted by doing something else. Maybe they just don't have a good routine, or they don't have the good tools. And often these ideas for fixing the problem will come from the nurses and the managers at the front line. And so now we enter a zone of improvement, and this is where the rapid cycle PDSA, and we really are talking about changing performance over a matter of weeks, not years, in order to get to a new state within the clinic of improvement. At that point, you now say, okay, now we're at where we need to be, and now we need to just keep an eye on it. So you enter the second zone of control, where you need to have a system inside the clinic to know whether or not you are able to keep up that good performance, because it might just slip. And as Jeanette showed, by going back and looking at the clinic a year later, often there is slippage, and it's usually because it's not embedded into the new protocol, or the person who was driving and keeping an eye on things has left. These are sustainability is a huge issue. So all of this goes back into a quality planning system. So I've superimposed here some bars on here. So this could be a quarterly review process where somebody comes in and checks in on what's happening. So if it's done frequently enough, you could track a process like this through external review and help the staff to get improved. My point, though, is that if you're going to use external review, it's probably better to use it for the kinds of things that Jeanette was talking about, to get the clinic from a poor physical state of being able to deliver equality to a much better state, and rather use internal reflection, internal monitoring. Now, both of these systems have got problems when it comes to measuring data, and I'm going to talk about this. So the QA approach typically uses the long PDSA cycle. So there's a problem. There's increasingly in modern systems like Jeanette was talking about, there's engagement of the staff, there's engagement of communities. In an analysis, a plan is developed to do things in a different way, and then to come back and study and see whether it's done properly the way you want it. And if it is, great. If it's not, you have to send it through the cycle again. The drawback about this is that it's a very long cycle. The advantage is that you can obviously track a lot of different things that you're trying to study. The alternative is this, not alternative, but the additional component of quality planning sends a problem through systems analysis at the front line, but then moves into this rapid PDSA cycle. And you'd only throw it out into an implementation, a new protocol in the clinic, after this cycle has gone around quite a few times. And then you are happy, just like I showed you about the oxytocin improving to the level that you want. You say, this is the way now we do things in this clinic. And it could be a manager showing this across a whole system. This is the way we do things across a whole district, because of what we've learned from all the multiple PDSAs and the experiences from the clinics. At that point, you implement and you have a much better chance of succeeding. Now, this cycle here then goes back to quality control, internal quality control, where this nurse gets data every month on how much hemorrhage, how many women got hemorrhage this month. This is her internal control mechanism, where she knows that and typically we encourage people to look at outcomes to know if your system is working for this internal control, because they can't keep their eyes on 240 things simultaneously. They can only probably keep their eyes on 8 to 10 things, and we encourage people to look at outcomes, and then only if the outcomes are problematic. In other words, if we had a spike of women with hemorrhage this month, we'd have to go back and then start looking at the processes. Were all the women given oxytocin, and then keep a closer eye on that as an improvement project. But it becomes much easier if you're just following a few key things that tell you that your clinic is, in fact, on track. All of this information then goes up back into the quality planning system. So I want to stress the fact that both systems in a big system like the South African health system, you really need both. You need continuous internal control mechanisms that the clinics can see their data on a run chart, on a regular basis and see whether they're slipping and understand that there is normal variation. Some months they'll do a bit better than others and not to overreact. And at IHI, we spend a lot of time teaching frontline staff and managers about how to react to data, how not to underreact to it, and how not to overreact to it. But then for verification, it is very helpful to have this intermittent external assurance, and you can divide up what you're tracking. So you can spend more of the efforts with the external assurance systems on inputs, on the drugs, on the people, on the IT systems, on the management competencies, etc. And you can spend more time on continuous internal control, on looking at either outcomes. Did mothers die? Did mothers get hemorrhaged? Did patients get started on TB treatment? And if there's a problem, they can start going back down the chain to look at if the processes were done, and if the processes weren't done, look at what the inputs were. So if we look at the comparison between continuous internal control and intermittent external control, we see the important differences are that it's internal control is part of local engagement in improvement on a very continuous basis. Excuse me. It's important to realize that this is a kind of an ideal state, that you can't do this unless you've got the processes that Jeanette described actually in place. It's a more mature system that will be able to take on more responsibility. It does encourage more accountability for performance of the frontline staff and the managers. It does suffer from unreliable data. You can't believe the data that is initially collected because people aren't used to collecting quality data to help them improve. They're doing it because someone told them to collect the data, and it's notoriously unreliable. It'll tell us whether the system is in control or out of control, and it allows for rapid response. So we're talking about responses that happen over weeks and months. The intermittent external system is part of a very important verification process by managers. It's more important in systems that are really trying to get themselves sorted as a starting point, and building reliable systems across very large systems like we just saw. It's very assuring for manager, but for the frontline people, sometimes, as Jeanette said, they thought you were just maybe policing them. I'm not sure what the resistance was at the beginning, but often external measurement feels like policing. And so if you can switch it over to accountability at the front line, that's a real advantage. The data reliability is not assured. It's susceptible to gaming. Many of this, especially the accreditation systems and the other inspection systems, find that people will give them the results that they want rather than the true results. It's an intermittent monitoring system, and you know, if you've got a very big system, you may only be able to get to them once a year. And so, you know, you would love to have something on the side that works with that that's more continuous. And as a result, your response may be slower. So you're talking about annual response, whereas you might be able to get fast, very targeted improvement. This is much more comprehensive, obviously, because it covers these all of these 240 elements, whereas you may be just working on 2 or 3 things for your internal improvement system. So that's basically all I have to say on this, Bob. I don't know if you want to take any questions now or you want to keep moving.
Yeah, thank you very much indeed. I mean, questions are coming in, but maybe, Soji, we can you can give us a very brief overview of something what came out of the recent forum, and then we'll pass on some of the questions. So, Soji, over to you.
Thank you very much, Bob, and I will make it brief. So we have the first Africa Forum on Quality and Safety in Healthcare that was in Durban last week, and was really a great event because it really gave an opportunity to showcase a lot of improvement initiatives from across the region. And it was really regional. We had about 67% of participants coming from outside South Africa and 34% from South Africa. And over 80% of the speakers were actually African-based improvers who were doing a whole lot of wonderful things, and that really connected with the people who felt that this was an opportunity to showcase their work at various levels. And so you had people who were engaging from the national level, from district level, and from the facility level. So if you look at this particular slide, this lady on the right-hand slide is a sub-district supervisor overseeing some quality improvement initiative in tuberculosis care. And she talked about this being her first presentation at an international meeting. And it was just so inspiring to listen to people like her. And there were hundreds of, 250 posters actually, and many sessions across leadership, improvement science capability, safety, infectious control, patient and family-centered care, use of technology, and a number of important side meetings that we arranged coincide also with the forum. So here, IHI had been leading some case studies in 5 countries that have been implementing national healthcare quality strategies: Nigeria, Ghana, Ethiopia, Mexico, and Scotland. So over a 6-month period, we had gone back to these countries, some of them implementing quality health strategies over a 10-year period, and some more recent over a year. And we try to tease out the elements. What does it really take to be able to manage a change process from the national level and to link it up to some of the detailed process improvement initiatives that Pierre just spoke about? And it was clear that some core elements stuck out, like among these countries and throughout the sessions we talked about structures for quality, identification of priorities, formation of teams at various levels within the hospitals, linkage to communities. So in some instances, we learned how community members have been co-opted into improvement teams, and how that whole system of learning enabled the various lessons to be plowed back into the system in a bi-directional way. So from the facilities up, and also from the national level right down. And also, it offered an opportunity as the forum as a whole for many other organizations to also engage. So ISQA, for example, was on board. That is the International Society for Quality in Healthcare. Had an opportunity to engage with African Community of Practice. WHO had its own meetings, and there were, although it was an IHI-led event, we did a pretty good job, I would say, of bringing a number of organizations to form part of the scientific committee. So URC was on board, JAPIGO, HealthQual, and some African-based organizations that we've been working with, like Ubora Institute from Ghana, Maikanda Trust from Malawi. So it was great. A total participant number of about 603, and already there are a lot of questions coming about when we are having the next one. So Bob, I think I'll leave it here for us to have sufficient time for the questions.
So Soji, thank you very much indeed. So we'll have a few. Again, if you could send any questions you have on the chat line to all panelists, and we're trying to get through a few of them. I'm going to start off with a question that's come from Niloufar Pollard, which talks about Pierre, whether you could, from your experience, well, Soji, and also from across Africa, you could talk about whether these systems that you were talking about, how well they work in resource-constrained settings, or is this something which can only really function when resources are adequate, infrastructure, staffing, and what happens in where budgets are very, very constrained?
Well, Soji works only in Africa, or primarily. There's a huge amount of experience in the variation in resource constraints, and we work in some very poor countries. The resources are a constraint, and you will hit a wall if you don't have the drug. And we found that in Malawi with antenatal corticosteroids. Within weeks we had got 3 major hospitals routinely delivering antenatal corticosteroids to mothers in preterm birth. And then suddenly we found that we were so successful, we'd used up the country's supply of hydrocortisone, and so suddenly there was no treatment. So absolutely, and I think Jeanette made the point as well. I think that you can use quality improvement thinking and systems thinking to really get at waste and try to make the most of the few resources that you have. But I'm interested in Saji's thoughts on that.
I think that over the 10-year period I've been engaged, that would be the greatest lesson, which is that there is a role for the quality control, there is a role for quality planning, there is in fact a role for inputs, supply of inputs. Because initially there had been the sense, or maybe QI advocates had positioned it as purely process improvement that can be done in resource-constrained settings, not requiring inputs. But over time, we've come to accept that one needs to work in a complementary fashion. And we had this interesting project in Ghana where we thought that we're not diagnosing enough maternal depression cases. We did process improvements, we tested innovative ideas. The cases were diagnosed, but then we didn't have antidepressants to manage them. So this certainly works out. But the key thing is that there's just an unbelievable amount of waste. So in the project Spice Alive that we run in Ghana, for example, there was not an extra doctor that was supplied to any of the facilities, not an extra incubator, not an extra medication that was supplied. Working within the resources already available in the health system, we managed to reduce under 5 mortality by 34% in 146 hospitals. So that my immediate impression was that there is a lot of preventable deaths that were happening, and with simple process improvement, simple tweaking of processes like prioritizing the most critically ill, coming up with a checklist to identify the most critically ill, simple interventions, it was always possible to make a difference. And then when one got into more sophisticated areas like newborn care, where one needed to focus more on the clinical processes, then perhaps we needed to get a little bit more sophisticated. But at this point, there's no doubt that the process improvements actually make a difference.
Thank you for that. So a couple more questions. One about the data. How can we decrease the burden of data collection? I mean, a lot of this is data-driven, and there's a lot of data requirements in the health system already. How can we do this and save the energy of health workers in making the improvements and not just spending all their time collecting data? Then we have a question, can you just briefly, I think you covered it in your presentation, but could you just quickly give us the difference between quality assurance and quality improvement so that's nice and crystal clear in everyone's mind? And then lastly, could you say a word, this is from Diana Silimperi, about how you prepare those for these internal processes without blaming individuals? How do you create the environment for improvement through leadership?
Okay, so I'll just take very quickly. The data collection is a very, I don't want to understate how difficult the data collection piece is, particularly when you are moving towards internal data collection that you're relying on for doing improvements and for quality control. So, for instance, in South Africa at the moment, we're working, with over 100 clinics and sub-districts where we haven't been able to believe the data for TB care over time, and much of it is incomplete and inaccurate. So this is an age-old thing, but what we find is you have to invest in that. So we invest in training at the front line about the importance of data, the use of data. We invest with data managers to make sure they really understand its usefulness. So I think there's an investment piece, there's a time, there's a patience piece, but you have to, in the meantime, you do need some kind of verification system to know what's going on. And once it all comes together, as it does, over a period of months, you can start to rely on the data that is being routinely collected. So it's a worthwhile investment in the data. QI and QA. So quality assurance is the monitoring of data from the outside that presents a clinic or a facility with a snapshot of its performance. And quality assurance of its own does not necessarily imply that you're providing a method to improve. So Jeanette's system not only reviews the performance once a year, but then they embark on a process of system analysis and some help provided to improve the system. So it's a bit of a hybrid model. Quality improvement is really the structured process to redesign the system to get you to a better state. So there's a saying, every system is perfectly designed to get the results it gets. So if you're getting a bad result, it's because the system is designed to do that. And you have to redesign your system to get a better result. And it's that redesign process, usually with typically either just sitting down and coming up with your best solution, as Jeanette described, building on the experience of peers, or a more iterative process where you do rapid cycle improvement multiple times to get you there. They're both on the spectrum of quality improvement. But the big difference is who does the review, whether you do it yourself or whether it's done from the outside. And if it's done from the outside, typically in the past, that has been called quality assurance. So do you want to talk about creating the environment for improvement?
Well, I think that the key thing is alignment with priorities. So if whatever initiative comes off as something in support of an existing priority within leadership, then the leadership is more likely to accept and be supportive, as opposed to it being an external injection. So in some places, it was very strategic to align with a Millennium Development Goal, which the leadership was already rallied around. The second thing is also to move away from the language of blame and judgment. If it was felt that we were all trying to support, because we are all aligned to either reducing mortality or improving survival or improving the care process, then change was not threatening. The third thing was also create space for people to be able to express their true frustrations with the system and not to wait to get 100% buy-in before you started. So the people who wanted change in the system would be the people who would start with and get little results to be able to then demonstrate to people that actually it is possible to change some of the outcomes that we are recording. So I mean, these were simple strategies that we used to be able to get buy-in and to create that safe space for improvement work to happen.
Thanks very much. We're into the last 5 minutes, so I'd like to return to South Africa and to Jeanette and Shida. We've been hearing about the thinking that's going on, or globally really, around quality improvement, both internal and external. And we heard from Pierre about how South Africa is like a hybrid model. And we also heard from Soji about some of the thinking that's coming out of Africa more widely. So Jeanette, Shida, over to you. Any sort of final reflections about what you've heard from Pierre and Soji and any sort of implications for the South Africa Ideal Clinic program?
Bob, yes, listening to Pierre, I believe what he's describing is continuous quality improvement with regard to clinical processes. For example, how do you design a system for improving how you manage postpartum hemorrhage, for example? And so you could go into different kinds of clinical, whether it's internal medicine, obstetrics, or surgical procedures, and do those quick interventions, assessment and redesign of the system to be able to do better when managing clinical cases. And I believe what Pierre and Soji is talking about is complementary to what we're doing with the Ideal Clinic program. Because what we are doing is we are preparing a platform for clinicians to be able to provide better services. So you're providing the platform for the kind of continuous quality interventions that Pierre is referring to be able to happen. And I think he explained it like that as well. For you to have better processes for managing postpartum hemorrhage, for example, you do need health staff, first of all, and then you need a space within which to work, and you need the equipment to apply to your continuous quality improvement in terms of continuous quality improvement. So what we found in South Africa is that we keep on expecting from our clinicians to do better without providing the environment in which to do better and without giving them the standard operating procedures and clinical protocols to even just start to do better. Let me stop there. Maybe a quick word from Shaida.
So I would tend to agree that the ideal clinic is to an extent a hybrid model. So there are some internal monitoring controls built in PIA and SOCI, especially in component 2, which looks at the clinical management of patients. We have built in the use of the data at local level to enhance health professionals' understanding and being able to pinpoint the weaknesses in terms of them achieving the targets that have been set for them. Similarly, in terms of clinical audit processes that are undertaken on patient records to identify where protocols are not being adhered to, and that this is done at a local level, and that there's immediate interventions to say, how do we improve the quality where we're seeing that quality is slipping, and what is it that we need to do about that? So yes, it is a hybrid model, and I think once you unpack a little, especially in terms of the amount of structure that underlies the different elements, especially in component 2 and 3, then you would see it starting to get to the issue around quality improvement in clinical care. So it may not be, the full Monty in a sense, but it starts providing that to say, whilst the platform is being prepared, we're also not leaving behind the issue around clinical care. And thank you, Bob. That's, I think, enough from me.
Well, thank you very much for that. And I'd like to thank all the panelists for their great contributions. It's been a very interesting hour and a half. I personally have learned a lot. And so thank you very much to hearing about the latest science and thinking from Pierre, about the growing movement on quality across Africa from SOGI, but also from South Africa and all the very interesting and impressive work that's happening around improving the quality of primary healthcare services. I think we've all learned from that. So thank you very much for your time, and I look forward to your engagement in future events. Thank you to everybody.
Thank you, Bob.